I'm Dr. Jay Khanna, Physician Executive Director for the MedStar Orthopaedic Institute and Chair of Orthopedic Surgery for the MedStar Georgetown University Hospital. Like most spine surgeons, I see patients with different types of conditions of the spine. Often it's spinal stenosis and they have symptoms of neck, arm pain, arm weakness or dysfunction, or back pain, leg pain, weakness or dysfunction. And I'll evaluate the patients like most physicians do by getting the history to figure out where the symptoms are coming from. We'll examine the patients to see what their strength is like, and then I'll take a look at the imaging studies with them, and I find that very important. And my stethoscope for evaluation of the spine is really the MRI. So I want to make sure almost all of my patients, or most of my patients, have an MRI study so I can see exactly what's going on in their spine and which nerves are compressed and which levels are involved. And then I'll go over the various options with my patients. And I often break the options down into three broad categories. One, to leave it alone and do physical therapy and medications. Two, to consider what I call interventional modalities, which are modalities short of spine surgery, such as epidural injections, facet injections, and different types of things to get a patient better. And the last option is always spine surgery. And I like to exhaust options 1 and 2 before we think about the option of spine surgery. There's a lot of new things on the horizon in spine surgery, and it's an area of very rapid development. Over the last several years, we've seen the use of more image-guided technology and navigation for placement of pedicle screws and other instrumentation into the spine. We also have newer technologies such as robotics now that are being developed, and things that we're using here at the MedStar Georgetown University Hospital and throughout the MedStar Orthopaedic Institute and our other programs. So we can use robots, intraoperative CT scanners, intraoperative MRI scanners to help guide our instrumentation and our surgery to make sure we do the best possible surgery for our patients while minimizing any potential complications. It's very important to take a look at everything. So I look at them from a spine standpoint, but we have to look at them from a neurosurgical standpoint, orthopedic standpoint, rheumatology, neurology, physical medicine, rehabilitation. And then we also have to consider their other factors. What are their social circumstances, their physical circumstances, and really are taking care of the whole person, cura personalis. I think patients should come to MedStar Georgetown and the MedStar Orthopaedic Institute because we have great physicians. We've got great surgeons, and I'm really proud and honored to be working with some of the leaders in the field right here in Washington, D.C. at MedStar Georgetown. I really love the field of spine surgery. The ability to help a patient who's suffering and can't walk or can't move an arm or a leg and be able to relieve those symptoms and get the pressure off of their spinal cord or their nerve roots and stabilize their spine is very satisfying, and I feel very lucky to be able to help patients with these types of conditions. So back pain is very common, and there's many things that can cause back pain. Spinal stenosis is one of them, compression of the nerves in the back. Degeneration of the discs is yet another one. And other conditions around the spine, such as tumors, infections, obviously trauma, such as fractures. Most of our patients that end up needing surgery have spinal stenosis, or compression of the nerves in and around the spine. Spinal stenosis is very common. And spinal stenosis is really the compression of the nerves in the lower back that can cause leg pain, weakness, and dysfunction, or in the neck and cause arm pain, weakness, or dysfunction. And many of the times, the spinal stenosis can be treated non-operatively with physical therapy, anti-inflammatory medications, and various different types of injections. Epidural injections are one type. But when patients fail those non-operative management modalities, they may be candidates for spine surgery to get the pressure off of the nerves. Patients may require surgery for spinal stenosis if the non-operative measures fail. So we try to treat almost all of our patients first with physical therapy, anti-inflammatory medications, and various interventional pain management modalities, meaning epidural injections and different types of injections. If those interventions don't work, then we think about surgery, especially if the patient's symptoms are very severe, or if their MRI findings with spinal stenosis matches their symptoms. Spinal stenosis can be very debilitating. When patients have severe lumbar spinal stenosis, they can have severe back pain, leg pain, weakness, difficulty walking, A lot of patients will say they can't walk unless they lean forward on a grocery cart, for example. Some patients will have bowel and bladder dysfunction. Other patients with cervical spinal stenosis may have similar findings in their arms, with weakness in their arms, pain, numbness, dysfunction. So spinal stenosis can be very debilitating. But spinal stenosis sometimes is not so bad. And in those patients, we can treat them non-operatively with physical therapy, anti-inflammatory medications, and injections. There is a broad range of surgeries that we perform for spinal stenosis. And there's two broad categories. One is for the cervical spine, when we have spinal stenosis here, and the other is for lumbar stenosis, spinal stenosis in the lumbar spine. With regard to surgical options in the lumbar spine, we can break those down into two separate categories. We have decompression, which means getting pressure off of the nerves in the lumbar spine, and then we have stabilization or fusion, which means stabilizing the bones if they're unstable, or if we make them unstable by getting the pressure off of the nerves. So we can perform the procedure in different ways with minimally invasive techniques to make small incisions using special tools to get down to the spine, to get pressure off of nerves, such as with a disc herniation. And then we can also do fusion procedures by putting screws, rods, and different types of materials into the spine to stabilize the spine or realign the spine. If a patient has a scoliosis or a curvature of the spine, or if they have a spondylolisthesis, meaning a slippage of the spine, or, God forbid, if we have to take care of a spine tumor. Sometimes we have a tumor in the spine, and we have to get the tumor off of the spinal cord or infection off of the spine and then restabilize the spine. So there's many different surgeries that can be done for spine patients. So there's a lot of new technologies that we use for spine and orthopedic surgery. And we're very fortunate that the MedStar health system has provided us with all of these tools to provide our patients with the best-in-class care for their spine condition. So we have all the latest image guidance tools in the operating room, intraoperative CT scanners, robotics, and a lot of other very advanced tools that help us provide the best possible care for our patients. And it's very important to have those tools because they let us perform the surgeries in ways that allow our patients to recover faster, with fewer complications, less blood loss, smaller incisions, shorter hospital stays, quicker recovery, and back to their activities of daily living, which of course is the goal with many of these surgeries. The recovery time after spine surgery is something a patient and family will always think about. How long will it take me to get back to my activities? And when I was a resident, and I finished training about 18 years ago, patients could be in the hospital for a week after some of these surgeries. But now with the newer technologies and minimally invasive spine surgeries and better rehabilitation protocols, physical therapy and social work in the hospital, our patients can sometimes go home the same day. Depending on the size of the surgery, sometimes they'll be here for a day or two. But it's gotten amazingly better over the years because of the new ways we do things and the new technologies we have to help our patients recover from their spine surgery. We take care of a lot of patients with spinal stenosis, but there's other conditions as well that affect the spine. We can have scoliosis, which means a curvature of the spine, kyphosis, when a patient is bent forward, spondylolisthesis, where there's a slippage of the spine, disc herniations, tumors, trauma, infections. And one of the benefits of our group is that we have 10 spine surgeons in the MedStar Orthopaedic Institute, all in the Washington, D.C. area at our 5 hospitals, and our neurosurgery colleagues that we also collaborate with very closely on conditions of the spine that are also sharing our patients with us. And sometimes I'll see a patient and I'll realize there's another surgeon in my group or in one of my parallel groups that's better for this particular patient. And so we like to use a technique which I call demand matching. So some patients should only be taken care of at 1 or 2 of our hospitals. Other patients can be taken care of in one of our ambulatory surgery centers. Another patient might be better taken care of by one of my partners who has a special interest because I have 10 partners and we all know what we're all good at and what we have greatest expertise in. And so instead of taking on a case that I may have done once or twice, I may refer that patient to my partner who's done a couple hundred of these. And I think that's really the best thing we can do for our patients is to get them to the best surgeon for the given diagnosis at the right place in the right type of hospital or ambulatory surgery center to give them the best care possible.